So as we've heard, and the Canadian population is getting older, frailty is an increasingly common problem. We all know that. But the problem is that there's little evidence to guide the care of the seriously ill, frail elderly. And that's driven a lot of the problems and a lot of the issues that we've heard over yesterday and heard this morning. And without evidence, aggressive and expensive technologies are often used without improvement in outcomes, causing potentially undue suffering and wasted healthcare resources. We know that a lot of spending occurs at the end of life, and 20% of all healthcare spending occurs in the last year of life. This graph highlights the increasing spending with increasing age. So by the time that you're in your 80s, the amount of healthcare dollars spent per year is around $16,000 to $25,000. And whenever we talk about increased costs, and one of the reasons why TVN was funded was to look at technology. And some of the estimates are that technological advances have been estimated to account for up to 65% of all increases in healthcare spending. So, and now not to say that all technology increases healthcare spending, some of the curative ones do reduce healthcare spending, but those are in the minority actually. Most of the things that we implement into practice do increase healthcare costs. And the problem is that a lot of the technologies that we use have actually not been well studied in this population. And in an era of increased resource scarcity or resource or focus on how we utilize our resources, the evaluation of new technologies or any technologies that we use will need to be increasingly rigorous. We're going to have to demonstrate an effect on patient-centered outcomes, including quality of life, and we're going to have to demonstrate cost effectiveness. So the need for TVN, and this gets back to what I just said about the lack of evidence. There's lots of questions faced by decision makers, by clinicians, decision makers in regards to how to treat this patient population. So, for example, is a healthcare intervention or technology effective in this population? It may have been studied, but not studied in this population. Is the risk-benefit ratio similar to that of younger patients? So statins, for example, statins to lower cholesterol have been studied, but are they of benefit in a 90-year-old who has elevated lipid levels? Not studies. Is the risk-benefit ratio useful? Is the technology good value for the money? Is escalation of acute care warranted? Towards the end of life, there's always the perception that we need to intensify aggressive technologies. Is that warranted? Should our resources be better served by implementing better end-of-life care or changing the goals of care such that comfort and are better? All these questions need to be answered. What is the most appropriate setting for care? Again, we don't know. And where do patients, families, and their preferences in all this? All things that require to be studied. So TVN was funded originally as an NCE to develop, evaluate, and disseminate information about the use of healthcare technologies in the broadest sense for care of the seriously ill, frail elderly and their families and caregivers. Now, when I say technology, I mean in the broadest sense. So I don't mean the technology in the traditional way that we normally think of. So for example, a mechanical ventilator, a dialysis machine. Technologies, in the way we mean it, is everything that can be used for the care of a patient. So it could be a protocol, it could be a medication, it could be a study looking at the setting of care. And unfortunately, technology, we tend to think of it in the narrow sense, but for our purposes, we want to be all-encompassing and look at everything that may be used to look at to care for this patient population. And ultimately, we want to ensure that elderly patients receive the right treatment in the right setting at the right time. Very lofty goal, but I think that's where we have to go to make a difference. So just a bit more of the history of where we came from. The original TVN originated from the collaboration of three networks, which was the Canadian Critical Care Trials Group, CareNet, and Nutric, in which these problems are becoming an increasingly bigger problem. So in critical care, we see this all the time. We see elderly patients come in without discussion of end of life, without, and also where we apply expensive technologies, and a lot of these patients don't actually benefit from those technologies. So the original proposal came from the collaboration of those three networks, but it's expanded dramatically outside of what the original scope was. And the key recommendations when we were funded from the networks of centers of excellence is that we needed to have a research agenda specific to TVN. We needed to be value added. And also they had a lot other recommendations that we needed to train for a wide variety of healthcare and social care professionals. We needed to include bioethicists and elder law specialists in the network. We needed to actively participate, actively engage participation of patients and families. We needed to have stronger linkages to receptors and stakeholders. We needed to encourage cross-disciplinary work and have international links. And we've addressed these. We've come a long way to develop the network. We first embarked on a consultative process, strategic plan development. We consulted with multiple audiences, stakeholders, research groups. We had network-funded protocol development meetings. We interviewed selected partner organizations. We engaged our board. We had network planning meetings. And through that, we developed a broad strategic plan. And we also partnered with CIHR. CIHR has an Institute of Aging. They're also engaging in research in this. And we partnered with them for two reasons. One, we wanted to avoid duplication of efforts. And also we wanted to leverage available resources and prepare for possible coordinated funding opportunities. We had held 5 exchanges across Canada with a variety of stakeholders. And ultimately, this is what our strategic priorities look like. They're highlighted in the three circles, and in the center is we want to match care to values. We want to take into account the values of patients, caregivers, into everything that we do. And we have 3 spheres. We want to empower, engage, support patients, families, and caregivers. Ultimately, we want to improve clinical outcomes, and improve care across the continuum is an important focus for us. And as we heard before, it's the breakdowns that when you go from one setting of care to the other, which increases the stress on families, caregivers, leads to worsened outcomes, and ultimately doesn't serve this patient population well. So the scope of the work, the scope of the work increased from the original proposals. The scope of the work is older Canadians with significant life-limiting illnesses, in which there's a question of what technology to apply, and again, technology is in its broadest sense, and that to improve their survival, quality of life, or quality of death, including end-of-life care. We're focused on all settings of care, from acute care to critical care to community care to residential care. And we want to utilize a family-centric model of care, including the patient's family and informal caregivers. So this is an extremely wide, our strategic areas are quite broad. And the goal is that over time, we want to identify and prioritize gaps, so that we can focus on the most important within our broad themes and lead to targeted initiatives so that we can make the biggest impact. One of the areas that we don't want to focus on is the well aging. We want to narrow our focus to seriously ill, frail elderly, in which there's life-limiting illnesses. Again, that's huge. We don't necessarily have those resources, but we want to identify the most important gaps where we can make the biggest difference. And we've had lots of discussion as to exactly how to do that. And one of the things that seems to be emerging in the network is the focus on the intersection of the seriously ill, frail elderly with the acute care system, since that seems to be one of the areas which is increasingly problematic. We spend huge amounts of resources in Canada on the acute care system, and the intersection of the seriously ill, frail elderly with them a lot of times leads to bad outcomes. So our focus is either to look at ways to prevent the need for acute care, or if you do require acute care, look at ways to either return people to their baseline function or getting them back out to the community quicker, or prognostication to determine where and when intensification of care is either needed or not. Where intensification of care is not needed, then institute better end-of-life practices. And through that, through our strategic priorities, we are implementing four themes, and we're appointing theme leads in all these areas. And the four themes are that are going to be where we've identified the biggest gaps are to improve end-of-life care, advanced care planning, improve acute care, critical care, optimize community care, residential care, and optimize of transitions of care. So we're going to have people that are appointed to those that are going to lead our research agenda going forward. And all our current research, all our efforts do fall into those areas, but those are going to have to become increasingly focused as we go forward. And so at the end of the day, in the long term, we want to improve care, and that's through the measurement of patient-centered outcomes. And we want to improve efficiency. We want measurable healthcare resource utilization outcomes. These are things that do not happen within a year. They're not things that happen in a couple of years. That's our long term. And how are we going to do that? By looking at a targeted research program, by training highly qualified personnel, by developing more networks and partnerships, and engaging in knowledge translation. So that's our background. That's where we are. Now I just want to spend the rest of the time looking at our areas, which are the research program, the training of highly qualified personnel, and knowledge translation. So our research program, so first of all, these are the elements of TVN funding. So any funding that we give has to fill a gap in the TVN research landscape, which it's obvious. It has to be multidisciplinary, which is a bit different than other funding agencies. It has to be multi-sectoral, has to be multi-institutional. It requires 20 to 25% partner funds, which can be either in kind or cash. It has to integrate knowledge users, patients' families. There has to be embedded training of HQP or highly qualified personnel in any funding, and it undergoes a two-step evaluation process to be as rigorous as possible. We evaluate it for scientific rigor, and we also evaluate it for fit within and contribution to our mandate. We have three different granting programs currently active. Our core grants were our biggest grants, and we've had two competitions in the fall of 2012, one in 2013, which is just starting to ramp up. There's going to be updates about the grants given out in the fall of 2012. On the screen are listed some of the titles that we've currently funded. We have smaller grants, and these are for pilot studies, feasibility studies, and for novel approaches. They're 1 year in duration. We've had a couple of competitions. We do have an active competition now that was announced at the beginning of September. The letter of intent is due in October. The full application is due at the end of October. The full details are on our website, so please look there if you're interested in applying. If you have funding and if you need funding and your area of research focuses on the seriously ill, frail elderly, we'd like to hear from you. Those are the examples of some grants that we funded from the 2013 competition, and those are just ramping up now. We're very excited about our last one is the Strategic Impact Grant Program. This was an innovative way of catalyzing partnerships, collaborations between researchers, knowledge users, stakeholders, and we use an integrated knowledge translation approach. One of the things that we found in our first couple of competitions is that the science tended to be very good, but the level of collaboration, the involvement of either patients, stakeholders, knowledge users in these grants tended to be not as good as we would like. So by doing this type of competition where we actually ask researchers to submit expressions of intent and then bring the researchers together along with knowledge users, stakeholders in the same room to actually collaborate on developing the final protocol is our way to make people actually develop or researchers collaborate with the end users such that the knowledge product or the research that comes out of it is more relevant to the system as a whole. We've just finished the whole process. We're just going to adjudicate the 4 grants that came out of there, and then we'll embark on an evaluation. We are going to release another one of these calls for proposals this fall, so please be on the lookout for that. It is a different way of conducting research. It is a different way of catalyzing people to work together. So one of the things that we always say is that this is not a typical CIHR grant. You have to be willing to work with a whole variety of stakeholders to be part of these type of competitions. But I think only through these type of ways, and we probably I'm sure we have to modify it to improve it. Only that can we develop the innovative type of research that's needed to address some of the challenges that we've all heard. So that's a brief update on our research. We do have a big, strong component on the training of highly qualified personnel. So our program is a collaborative, multidisciplinary training program. It's designed to improve trainees' viability for future employment and support to trainees to facilitate their success. We have a multidisciplinary training committee with broad representation. And thus far, we have over 100 trainees representing 23 disciplines. There's a variety of categories of trainees, including those that are project funded, that are part of the research proposals. There's undergraduate summer students that we funded. We've had 2 years of funding for this. The posters are up there. Please have a look at them during the breaks. And then we also have an interdisciplinary fellowship program, which is 2 years. This is our highest level of training, and we're continuously improving that. We want to link that to a master's or a PhD certificate, and we will be doing that over the next little while. We have a pilot project with Queen's that has just started. We just recently did a gap analysis and are filling the gaps with our last competition. So finally, just going to end off on knowledge translation as to where we are and then address the future. So our knowledge translation, we have a KT committee, which is chaired by Jana. And the activities that knowledge translation there's 3 types. We have a strong focus on integrated knowledge translation, where we actually involve the users and knowledge users and stakeholders in the development of the research. And the good example of that is our strategic impact grants. The end of grant KT, that's where we disseminate research, the results of research that we've conducted. And we've had a strong knowledge synthesis activities where we actually, where we are looking to integrate existing knowledge to look to see if there's areas where there's gaps we need to address, or there's areas that need to be implemented into practice. And this afternoon is the results of our first knowledge syntheses that we funded are going to be presented, and that will and that'll be one of the first examples of the fruition of things that we funded. And then there's the big item, which is the corporate KT, where we try to influence policy. So this is our annual conference. So this is going to, we want to position this to be the preeminent annual conference on the frail elderly. We had over 100 participants last year. This year we're up to about 200. Next year we hope to be bigger. We had a couple of pre-sessions which were widely attended. So we had a technology day on Saturday looking at focusing at the hard technology. Yesterday was the patient engagement or citizen engagement workshop or public workshops. So one of the things that we need to do is influence policy. And in June of next year, we're going to have a national forum on the seriously ill, frail elderly, where we've already started to invite stakeholders, decision makers, peoples in different levels of governments to speak with researchers to develop a national strategy. We've partnered with the Muscedere Center for Business Research and Healthcare at Queen's University to do that. And hopefully through this, we'll be able to develop white papers and start to actually move the national consciousness of focusing on the frail elderly. As I said before, we had technology symposium. We're partnering with other national centers of excellence, and this is to develop innovative, disruptive technologies that would be useful in this patient population. Canada is a bit behind in this. There's a lot more innovation in some of the other countries in the world, and we're just so we want to catalyze some of these, but this is not going to be a big focus for us. Ultimately, what we want to do is actually technologies that are developed, we want to actually rigorously evaluate them in our patient population to look that they actually address this patient population. They actually look at patient-centered outcomes. And it's starting in October. We're going to have monthly webinars. So the first the first 3 webinars are, so October 1st is an introduction to the NCE TVN. November 4th is we're going to have one defining frailty. December 3rd is one on knowledge translation. These are going to be continual. They're monthly. They're designed to be state-of-the-art in topic areas related to the seriously ill, frail elderly. We've embarked on a palliative care partnership to survey for palliative care practices. We're going to hear about that shortly, and we have other knowledge translation events, again bringing researchers, decision makers together to address this problem. So that's where we're at. I just want to finish off in the next little while with what the future looks like and where we need to go. So this is TVN by the numbers. Have you heard some of these? This is already out of date. We have over 200 attendees at this conference. This year, we've had 10 funding competitions that will give out more than $10 million in funds. We have more than 100 highly qualified personnel. We've invested in summer student and fellowship programs. And we have 137 organizations that participate with TVN across a wide spectrum, and that number is probably out of date. It's increasing all the time. Basically, there's lots of people that are active in this area. We want to bring everybody together. So the more partners, the more organizations that we can have a dialogue with, the more successful we will be at the end. So we want to continue to build the network. We're going to focus increasingly on partnerships, on stakeholder engagement, on knowledge translation, heading off to the year 5, where we start to disseminate the results of some of the knowledge that we've built, that we've commissioned, or that we've funded. And then we have a 5-year mandate, which is due in 2017 or ends in 2017. We want to increasingly work towards reapplying. We potentially could be funded another 2 times to go to 2027. And increasingly, all our efforts are going to focus on developing larger scale transformative projects that we can actually start to articulate the difference that we've made for the seriously frail elderly. And the conceptual path is that we need to articulate what we look like in 2027. That's 15 years after the start of our funding. Everything that we do, every activity that we undertake, every partnership that we do, ultimately has to improve the outcomes for the seriously frail elderly. And at the end, by 2027, we need to think how we're going to get there. If our goal is to improve the care that we deliver, that's our ultimate goal. Not to say that we won't make differences before then, but we want to have a transformed healthcare system for this patient population by 2027. And all our activities have to increasingly have the long-term focus in mind.